Assalamu alaikum. I'm Dr. Saad, AlRashidi, radiation oncologist at King Fahad Medical City. Thank you very much, Dr. Ahmed Maqlad, and the organizing committee, and Monica for inviting me to speak about the image-guided interstitial brachytherapy KFMC Riyadh experience. We'll go through this for the gynae and the prostate. So I trained in Canada and joined in 2020 KFMC, and I've been doing the brachytherapy, focusing in GU and gynae brachytherapy, and this is my background. So radiation or brachytherapy is really a high or the very high dose escalation and failure to cure any cancer in general, inadequate dose, geographical miss. And we know like surgery can eliminate the bulk of the disease, but when you offer the external beam radiation, the benefit or the main benefit of brachytherapy is really escalating the dose to a very high level in a way that you probably eliminate also like the bulk of the disease that's perhaps equivalent to the surgery. So image-guided brachytherapy, MRI-based, CT-based, or ultrasound-based. In general, for the common practice in the world is really the intracavitary brachytherapy, followed by the hybrid brachytherapy when you put some needles with the intracavitary system. And the interstitial brachytherapy is a unique experience in the world, and less than 50% in the world being practiced because it needs like adequate training as well as adequate equipped center to do this procedures and offer the service. So in general, the indication for interstitial brachytherapy in GYN for the cancer of the cervix is distorted anatomy, narrow vagina, and obliterated fornices, as well as really if there is no any anatomy or passage that the surgeon already removed the cervix, and also the patient had a recurrence, especially in the vault. And the bulky parametria that you need to push the dose in the far from the center. And for the vaginal cancer extensive disease, as well as if there is an extension beyond like the 0.5 centimeter that we cannot do with the usual intracavitary applicator or the cylinders. And the re-irradiation, of course, you want to limit your dose and constrain your organs, and there are many indications as well. The technique has been described long time ago, so there is a pre-needle tubes and template-based intraop, which is probably like shrinking in the world, and no one is really like doing it except a few centers in the world. For the cervix and endometrial, mainly the template base, as well as those hybrid applicator that they can also use as inner template or outside template. And for the vaginal cancer, mainly template based. So the evidence is really very firm, and there is enough publication and there is enough benefit if you offer at least the hybrid technique with those, especially the advanced cervix cancer, you definitely will provide a good dose with also like, respecting the organ at risk and also the benefit of reducing the dose to the adjacent organs, as well as reducing the toxicity later on and improving the coverage. And that's been shown in EMBRACE studies, as well as in those studies that I'm not going to go through it. So this is an example of the interstitial applicator technique. So you see the Muppet and the Saad that's been used in many centers in the world, in Canada and Australia, and some centers in Europe. And we use also like the similar Saad, or at least like analogy to the Saad template. There is also the Vienna ring, that's the old also variant system, and the Vienna 2, and many others. So at KFMC, we did have before the intracavitary system in place. Many thanks to my colleagues for offering the service before, and for a few now years, we develop or advance the service into hybrid as well as the interstitial system. So our workflow, as any workflow in the brachy, is the especially for the GYN pre-procedural assessment anesthesia, which we adopted or implemented the spine anesthesia. Of course, any procedure, the pre-op checks, and for the procedure, those patients undergo after the anesthesia, the placement of the applicator, the implant, as well as the immobilization of these devices, and then they undergo CT simulation. And if the MRI is available, with the MRI, as well as then the contouring or the volume creation, and then the quality, and then delineation and the delivery of the treatment. So that's in a nutshell. We utilize the spinal. There is a good review that we published on 2 years ago. That's the spinal analgesia really provide a adequate pain analgesia, and also like prevent the psychological impact of also like the procedure. That's also like there are studies now talking about it. So for since last years, we implemented this is example. I'm gonna go through like what we have in our services, the cylinders, the multi-channel cylinder that was implemented last June. And those cylinders really like very handy. So you have many channel, up to 9 channel, according to where you want, for especially the vaginal recurrences, as well as for the patient with the Volt disease, as well as the Volt prophylactic radiation. So for the other implemented technique, what we implemented, the Fletcher interstitial ovoid technique for cervical cancer last June. You can see the all the Fletcher system, and now replaced with the mini ovoid or like small ovoid, the interstitial ovoid, and it has the straight needle as well as the oblique needle. So once you put the system in place, you measure the needles, and then you fire your needles into a certain depth. So this will give you a really good dosimetric distribution. You can get far as you want into parametry, up to more, maybe like 3 centimeters away from the parametry. And this is one example. Also what we have implemented here, the 3D interstitial applicator technique for cervix cancer. Last September, you can see the anal ring replaced by the Vienna ring. This is a smaller one and can fit the patient nicely, as well as the hole in the ring that use it as inner template, so you can fire the needles and reach really a good distance from the cervix, and you can go straight in a way that you reach almost the whole pelvis there. And you can see like how confirmed the dose around that, and there is no limitation for this technique. We do also implemented the KFMCR interstitial technique for the cervix last November. So similar to the 3D interstitial, but this is a smaller ring. Most of the patients, they have like a smaller passage, so in that way that you cannot really like sometimes accommodate the traditional ring or the 3D interstitial ring. So the issue with this is you have to implant the whole system, and you require a minimum 14 needles to be fired here, and it has also the chance for putting a lateral needle. The last one we implemented recently is the Kelowna perineal interstitial technique using the rectal. It can be both the same, similar for the prostate, as well as with the manual. So you can see here is the Kelowna template from outside for large tumors, and it has the 3D, the interstitial cylinder. It has the oblique needles that you load, as well as the straight needles, and you implant the Kelowna from outside from the perineum, and then you suture the template, and you can again reach any tumor in the pelvis with this technique. So with the use of the ultrasound that we have here, the good thing for the prostate, you can really, even where like really trying to use it for the gynae, you can use it for the GYN, and you can also distribute the needle accordingly. This is for the GYN, and I'm moving to the prostate because there is no really time I want to show most. So we implemented the high dose rate brachytherapy for the prostate, really perhaps the first ever in the whole region. And we started last August. So the HDR technique and been used long time ago, and mainly the ultrasound-based technique, which is really the more appealing in the world, which is intraop radiation with the help of the ultrasound. And those who use 15 grain 1 fraction as well as supplemented as boost or for the salvage or monotherapy. And the evidence is again quite firm here from like the study Sunnybrook. And if you escalate the dose and from the Ascend RT, really you gain a minimum of 15% absolute gain for the biochemical control. This is the picture taken from when we implemented the first technique last June, and it was really successfully implemented here. We treated quite a few patients so far, but we developed our workflow initially. So you have this workflow that I don't have time to go through it, but basically you see the patient, you image them, and then you review everything, and then you introduce the ultrasound that I'm gonna talk through with the rectal probe, as well as the placing the needle. So here is after the spinal analgesia with continuous sedation, because you didn't want them to move. Those patients, if they move, it's terrible for the placement of the catheters. So here you introduce the rectal probe. Once you introduce the rectal probe, you inflate the balloon, and then you position your prostate the way you want, as well as you take the picture of the size of the gland. So once you get a good positioning, you then really implant the catheter according to the traditional way, with the pass distribution system that you peripherally and then medially distribute in the same shown in this picture. And this is a picture from our patient. Then once the catheter distributed through the gland, then you go through the sagittal view, and then you advance into the base. See this needle advance to the base of the prostate. And then once it's introduced or advanced to the base, then you secure them with the wrench from outside. Then that way they do not move. Once everything in place, we contour the volume, and really we follow Sunnybrook, there's Jekistro and these things, but we contour the prostate, and really the CTV is equal to the PTV, and give 1 millimeter margin radial to the urethra and 4 millimeter around, and we contour the rectum as well. So once done, we reconstruct the needle. That's really the biggest and the hardest job for that. We take a lot of maneuver to reconstruct the needle. So you see the needle reconstructed through the ultrasound. Once done, then you calculate your dose, and then you produce the plan. So this is example of our constraint and objectives, and you see the plan already produced, and you get like a very conformal, nice dose there. So this is for the boost. For the monotherapy, again, this is from Sunnybrook, and it's going on phase 2 trial. We use 13.5 times 2, 1 week apart, and we utilize it as well for the salvage patient. And the evidence is really good for the 5-year follow-ups, more than 97% the control for the biochemical control, and as well as for the salvage patient. Here I conclude, really the GYN as well as the prostate program is still in development, especially the interstitial program, and really it requires a lot of effort. Many thanks to the department, to my colleagues for their help and for their contribution to this really successful service. Thank you very much.